We are here to talk about adjuvant therapy and all the things around adjuvant therapy. It's relatively new, somewhat controversial, but I'll leave it to the doctors to explain. And another reason we're here is Dr. Anil Kapoor, who was our friend, our vice chair, and a passionate advocate for the kidney cancer patient. There are I'm trying not to get emotional. There's so many things that he did for kidney cancer in Canada and globally that we are so grateful to have known him and him to be so generous with us for his time and efforts. And he lives on in our video knowledge library. He has excellent videos there along with other doctors. And please go there if there's any questions that you have when you're visiting or have visited and you might need answers to. And he was the leader of many webinars for us. I can remember the first webinar I did as an ED, and I'll tell tales, but I was very eager and naive. And we had a webinar such as this of esteemed doctors that were offering information for our patients. And I spoke out of turn and he told me that I shouldn't do that very nicely, but he was the first person to tell you that you were doing a good job. He was always generous with that. He was also the first person to tell you if you needed to change something. So we're very grateful for that too. And here he is with one of his, and Dr. Ali Khan was on that panel at that time. He also did lots of in-person sessions for us across Canada and was really instrumental in getting us some of the top kidney cancer doctors in Canada to support. He was always up for fun. And we truly appreciate it. Here is Dr. Kapoor and Ranjana, who was his right hand for many years. They participated in our Green Lip campaign. And the gentleman with the yellow vest is Stewie, and he is a kidney cancer patient, and he rode his motorcycle across Canada. And he made a stop at St. Joseph's, so they made a big welcome for him. And to honor Dr. Kapoor and his passion for the kidney cancer patient, we and the researchers and the doctors, we've recently renamed the CUASF KCRNC Kidney Cancer Canada Award to the Anil Kapoor Kidney Cancer Research Grant. So going forward, he will still be a part of new innovations in drug treatments, surgery, and so on for the kidney cancer community.
Thanks a lot. Thank you, Christine, for organizing everything. Thanks a lot. A big shout out to Kidney Cancer Canada, St. Joe's Hospital, UCC, RI, all the stakeholders in this. And thank you very much for the board members to come and attend, and everybody, our research team, Camilla, and the patient groups who are attending this meeting today.
Camilla was my right hand. I
Yeah.
couldn't have done it without her.
Yeah. So I'm a urologist and a kidney cancer surgeon. I do kidney cancer surgeries. I'm based out of St. Joseph's Hospital, in this hospital here. And I had an opportunity, these are my disclosures. And as Christine talked about, this man was my inspiration to be a kidney cancer doctor, a kidney transplant surgeon. I had the fortune of being trained under him. So I had worked 6 long years with him, and I had learned each and every nuances that he used to do. And it was such a great time working with him. We miss him so much, as Christine talked about. He was a friend, a mentor, a guide, a surgeon, like excellent talent, a prolific researcher, well known not just in this hospital, this city, this province, the whole country, but throughout the world, for his innovations, for his surgical ability, and the kind of things he could do. We all miss him, and yeah. So for tonight, I thought, I've done some of these talks before when I was out west in Winnipeg. We did a bunch of those in person and some of those online. Usually, my job that I've been doing in the past is to give an overview about what the problem is, how we diagnose kidney cancer, and what are the different ways we can manage them, treat them. And for the purpose of today's talk, I think the theme was the newer advances in the adjuvant therapy section, because this is something new we have seen emerging for the last couple of years. And I thought it was important for our patients to know what their options are. Me and my partner, Dr. Lalani here, we have been very vigilant about the patients, marking them down, like who are the ones who would benefit from these therapies, and talk about these therapies with them. When I do surgery, I find somebody who would be eligible for this. We work in a very collaborative fashion and talk about what are the benefits, what are the downsides, and just have them choose what the options are and make the best decision. And our job is to help them make that decision. So I'll be talking about some of the statistics, diagnosis, what is the role for biopsy. Uh, I'm not going to talk too much about active surveillance because we are mainly talking about the surgical side. I know you talked about if ablation could be an option for, so maybe we can have that kind of in answer question answer session, and some of the other nuances about the surgical treatment and what is the risk of tumor coming back. Because until this time, we were treating everybody, be it stage 1 tumor, stage 2 tumor, stage 3 or 4. Once we take it out, we just wait and watch for them. If they come back, we start some treatment like systemic therapy, like TKIs or immunotherapy or some other kind of treatment. But I think we have more options available now. So worldwide, kidney cancer is the seventh most common cancer in men and about 10th most common cancer in women. From somewhat older estimates, there was about 400,000 patients diagnosed every year. And in Canada, the incidence was about 10 per 100,000. More recent statistics from our own Canadian cancer statistics last year, kidney cancer contributes about 3.2%. The incidence of newer cancers in Canada per year is about 8,000. And unfortunately, around 2,000 of them will not make it. Overall, the 5-year survival is about 70 to 75%, and 10-year survival, this is for all comers, about 64%. If you look at this image on the right side, I want to highlight and point out the bar, which is shown as blue, is the one that newly diagnosed kidney cancer patients. Majority of them, around 65% of them, are diagnosed in stage 1, some in stage 2, about 15 to 20% in stage 3, and rest are in stage 3 during their journey for kidney cancer. When we find somebody, I think most of the patients today are diagnosed incidentally. What it means by that, you go into a hospital to have something else checked up, and you do a scan, either an ultrasound or a CT scan, and they find something in your kidney. Kidneys are located by virtue of them that they're pretty deep seated. Even if there is a growth in the kidney, it can grow larger for a long time before it causes any symptoms. So asymptomatic presentation, meaning if we were looking for something else, we find something else, is the most common way how we find kidney cancers. Unfortunately, we still continue to get patients who have metastatic disease, about 17% of those. So ultrasound, CT scan, or MRI usually is the method how we characterize the spot in the kidney or the tumor in the kidney. Sometimes we ask for a specific scan. We call it like a kidney or renal tumor protocol, where they take the scan in without the dye and then with the dye, and then they take another sequence after about 10 minutes from the dye. Many times, depending upon how the tumor looks like, how the conversation goes with our patients, we would like to confirm a diagnosis with a biopsy by taking a sample. There are a variety of cell types, clear cell being the most common, then papillary, chromophobe, and oncocytic neoplasms. And then lastly, to know the extent of the disease. For example, if the tumor has gone into some other parts in the lungs or pancreas or other places, we may need some specific CT scan or bone scan or MRI scans. I would also want to take an opportunity to talk about the renal tumor biopsy or renal mass biopsy. It's essentially taking a small piece of tumor and get it tested in the lab to know it in fact is a cancerous tumor or not. What I talk to my patients is it should be considered for any patient. Let's say if we know that there is a tumor in the kidney, it measured 2, 3 centimeter or 4 centimeter, but we know based on the size of the tumor, there is a significant percentage chance that it may not be a cancerous tumor. So to know more about the tumor, sometimes we talk about, okay, let's get more information about the tumor and get a biopsy done. Or when we know, like we're talking about ruling in whether it's a cancer or not, sometimes we have to rule out, oh, if it's a kidney cancer or something else going on, like lymphoma. If there are generalized lymph nodes swelling throughout the body and we think, oh, there's something going on kidney which doesn't look like a kidney tumor, we may need a biopsy. If we think, oh, this tumor might be coming on from, for example, lung or bone or some other place, we want to know whether this is a true kidney cancer or something spreading to the kidney. When there is a diagnosis of infection in the doubts, or when we find somebody who has unresectable disease, metastatic disease, so that we can know what exactly is the type of these tumors, so that we can initiate and start appropriate systemic treatment based on the histology. Also, renal mass biopsy, we do quite a bit in small renal masses. Like somebody who has small renal mass, we talk about tumor which are less than 4 centimeter. We know from research in this area, not just the older study, but also the newer studies, if the tumor is less than 3 or 4 centimeter, a significant proportion, almost about 1 in 4 of them, may be non-cancerous or what we call benign disease. And even out of those who are cancerous, there is significant proportion that may be indolent tumors or tumors which are very slow growing with low malignant potential, and it's likely not going to be a danger to life throughout their lifetime. And now with more advancement in the treatment, we have more options available. We can watch them very closely. We can have a surgical option. We can have ablation or SBRT or cryo. And you can imagine if we're trying to treat everybody with the same approach by doing a surgery, we would be doing some unnecessary surgeries. We will be putting a lot of our patients under unnecessary risks, which is not necessary at all. And at the same time, our techniques of biopsy have improved significantly. Their sensitivity is better, specificity is better, and positive predictive value. That means if the biopsy results say that it is actually a tumor, the risk or the chance that they may be false are very low. The complication profile is better. And actually, my patients keep on asking me all the time that, oh, if we put a needle into it, is it going to spread the tumor? There have been no reports in contemporary biopsy series of any tumor spreading because of that. And certainly this is helpful in clinical decision making, shared decision making about how best we can look after our patients with the tumors. But at the same time, we have to be cautious when we approach renal mass biopsy. The non-diagnostic rates, for example, if the tumor is small, the chances for radiology team missing the actual spot may be high because it could be hard to locate that tumor where the biopsy needs to be taken. But with improved experience with different teams, the risk of non-diagnostic rates have gone down significantly. The negative predictive value about 81%. One limitation is that the actual prediction of the grade of the tumor, like how aggressive the tumor can be, is still not the best with biopsy. We get to know about the grade finally when we take the tumor out. Some of the special type of tumors, for example, oncocytic neoplasm versus oncocytoma, we're still not able to decide on them based on just biopsy. And cystic kidney tumors, for example, where tumors have a lot of fluid and some solid component, it may be hard to hit the solid component because there's a lot of fluid around it. So I usually advise my patients if the results of biopsy are going to change how we're going to treat the tumor, then it's better to go ahead with the biopsy. If the tumor, let's say if somebody who's 30, 35, 40 years of age, and we see a tumor which is 4 or 5 centimeters, no matter what the biopsy results come out to be, we're still going to go and advise a definitive form of treatment because the person is young and during their lifetime, they're going to need some kind of treatment and the tumor is big already. So even if the biopsy results come back as negative, we're probably not going to believe it thinking that, oh, we missed the actual spot. And on the flip side, if somebody has lots of trouble, for example, breathing trouble, heart trouble, they have a tumor which is 4 or 5 centimeter. No matter what the biopsy results suggest, we may say, you know what, we're probably going to keep an eye on things. We're not going to put you through a major surgery, which can be life-threatening itself. So if the results are not going to change the management, we may not do the biopsy or intervention with that. A little bit about staging. 7 centimeters is the cutoff, about the size of a peach. If it is within the kidney, it's stage 1. More than 7 centimeters, stage 2. If it grows into the venous channels, for example, into the renal vein or IVC, the tumor thrombus goes into one of those, or into lymph nodes, that becomes stage 3. If it goes beyond the girotas or the coverings of the kidney and potentially into other structures in the body, lungs, adrenal gland, pancreas, bones, then it becomes stage 4 disease. This is a good schematic trying to show the same concept I was just talking about. Briefly, for stage 1, surgery used to be the main option, but over the last, I would say 5 to 10 years, there are many other options. Active surveillance, ablation, like burning the tumor, cryo, mean freezing the tumor, or SBRT, like irradiating or doing radiation treatment to the tumor. Although all of them are still not as good as the surgical option is, but they still give a very good option depending upon how the conversation with the patient is, what our goal objectives is, and how risky doing the surgery for that patient. For stage 2 and stage 3, usually it's the surgical option, which is standard of care. For stage 4 disease, of course, Dr. Lalani will be talking about a lot of those, and systemic treatment in the form of either TKIs, immunotherapy, sometimes surgery in well-selected patients, and SBRT for focal lesions if they are isolated. In terms of current treatment, as I said, for stage 1, 2, and 3, mainly surgical. In selected patients, it could be active surveillance, ablation, cryo, radiofrequency, or radiation. And in terms of advanced disease, if it is metastatic disease, but with very limited number of metastases, sometimes we can take out the kidney and some of those metastases so that we can make patient completely free of tumor. But mind you, those are very selected patients where the discussion has happened in multidisciplinary rounds, tumor boards, so that everybody's on board with that kind of treatment option and patient is well aware of downsides. In terms of definitive treatment, we have 2 main options. One is partial nephrectomy, meaning, as the name implies, removing part of the kidney, or radical nephrectomy, meaning removing whole kidney. It's always preferable, whenever possible, to remove part of the kidney. Usually it's possible if the tumor is small, it's located in a favorable location where it's easy to remove part of the kidney. Whereas if the tumor is bigger, larger, more aggressive, some lymph nodes near the adrenal gland or involving the adrenal gland, then removing the whole kidney is the main option. When we decide about partial versus radical nephrectomy, some of the things to consider are size and location of the tumor. You can see, as depicted in this diagram on the right, all these tumor locations are somewhat favorable to remove part of the kidney, but if the same tumor was located near the blood vessels where that red and blue lines are, then it'll be hard to save the kidney, because if we were to take the tumor out along with those blood vessels which get disconnected, there's no point leaving a dead kidney behind. So location of the tumor and size of the tumor are one of the most important things. If somebody has only one kidney, they may be born with one, or they had another problem with the kidney for which it's not working, or they had to take out the other kidney for a variety of reasons. And if it's the only kidney, then usually we try and maximize our efforts to save as much of the kidney as possible. Similarly, if somebody has familial tumors, because those tumors keep on growing back time and again, we take out some of them, other ones grow. And it's very important to try and save as much kidney as possible because they will keep coming back. And the next set of indication, that something to think about how the kidney function is somebody already had kind of kidney disease that the kidneys are not working properly, or they are at high risk for progression in terms of high blood pressure, diabetes, kidney stones, or morbid obesity, that may put them at risk for progression of kidney disease. So we'll try to maximize and prolonging their kidney function. Same thing, partial nephrectomy, preserve kidney function, delays progression to kidney failure. And we've also noticed for kidney tumors up to 7 centimeters, radical versus partial nephrectomy, they both offer excellent tumor control. It's still not clear whether a tumor larger than 7, would it be similar? We're still working on some of those answers from our large Canadian cancer database on kidney cancer. But at the same time, partial nephrectomy comes at a little bit of price. As you can imagine, cutting the kidney out, kidney is an organ that has such a large amount of blood supply. It's cleaning your blood 24/7. If somebody has to cut the kidney out, they will be at high risk for bleeding. Yes, we do see those complications for partial nephrectomy, and about 1 to 2%, like 1 in 50 to 1 in 100 patients, will need some kind of intervention after the surgery. They may have a urine leak for which they may need some intervention, but overall, removing part of the kidney prevents long-term kidney failure. And there are decision aids. I think the Ottawa group has done an excellent job in this, and they have developed some decision aid for our patients to decide and make a decision whether they would want to go ahead with partial nephrectomy versus radical nephrectomy for something depending upon their goals and objectives and what matters to them most. I think special consideration and very important to talk about in about, I think, 5 to 10% of patients, we see tumor progressing along the vein, the tumor thrombus. It travels into the main renal vein, the blood flowing from the kidney towards the heart, and sometimes it can travel all the way up to the heart. Depending upon the extent, we classify them so as to plan the surgery appropriately. It's very important that we plan those surgeries by taking into consideration the size of the tumor, the extent of tumor thrombus, and what other services would be needed. For example, we need a liver surgeon. Sometimes we need a vascular surgeon. Sometimes, if the tumor is going all the way to the heart, we may need a cardiac surgeon along with them. We may need variety of other instruments and technologies during the surgery to monitor the location and extent of the tumor thrombus during the surgery. And needless to say, complete removal of the kidney with the tumor as well as tumor thrombus is paramount. Careful removal without leaving anything behind. And it certainly needs a lot of expertise, lots of planning expertise available locally, not just within the urology community, but also some of the allied services we may end up using for these tumors. Time and again, I think the question comes up, do we need to take out lymph nodes along with the tumor when we remove the kidney? As a surgeon, I do a lot of other surgeries, for example, bladder cancer and some of the upper tract urothelial carcinoma, where there is well-defined role for removing lymph nodes. In other words, I call them the roots of the cancer. If the cancer has gone into the roots, it's easy to understand that way. Unfortunately, in kidney cancer, time and again, efforts have been to see if we remove a lot of lymph nodes that are in the vicinity of the kidney, would that make our patients live longer? But that has not been the case, unfortunately. So routinely, if there are no lymph nodes enlarged with the kidney tumor, we don't advocate. It's not recommended to remove lymph nodes. But if there is any enlarged lymph node, we usually take out at the same time to know if the cancer has gone into the lymph nodes or not. Needless to say, if the cancer is actually in the lymph node after the kidney, it is a poor prognostic sign. Same thing about adrenal gland. Adrenal gland is an organ sitting right up on top of the kidney. It's a very vital organ in the sense that it makes a lot of hormones which are important for normal daily functioning of the body, blood pressure, salt maintenance, some other steroids that it makes. Our understanding about adrenal gland in kidney cancer has changed somewhat in last decade or so. It used to be classified as stage 3, but in last edition of cancer staging for kidney cancer, this has been upgraded because what we learned, patients who had adrenal gland involvement, actually we're doing quite poorly. So rightly so, it has been up stage to stage 4 kidney cancer. Either if it is directly involved, contiguous with the cancer, or there is a skip lesion, means there is a tumor elsewhere in the kidney, and there is some space between the tumor and the adrenal gland, and there is another tumor seen in the adrenal gland that portends a very poor prognosis. So as I talked about partial or radical nephrectomy, until this point, we were treating everybody with a period of surveillance and keep checking them based on their stage. Like if the lower the stage, we would watch them less frequently. Higher the stage, we would watch them more frequently. And then if ever the tumor comes back, we would check them and we would present the options for systemic therapy. So overall, about 30% of patients will have some kind of recurrence for all comers. And it would make sense, rather than treating with same stick, we would want to define what the risk profile is, if they are high risk and low risk, and people with a low risk can just be monitored, and people with high risk, if they can have some kind of treatment which could help them and prevent the cancer to come back. So there are different kind of models depending upon what we see. For stage 1 cancer, the risk of cancer coming back over the next 5 years is less than 10%. Stage 2, about 20 to 30%, and stage 3 and 4, usually about 30 to 40%. This is a little bit busy slide. This is the risk stratification based on the stage of the cancer and what the follow-up looks like based on Canadian Urological Association guidelines. There are a variety of tools available which determine the risk of cancer coming back. And one of the most common was developed at Mayo Clinic in Rochester, USA, Liver score. It takes into account the stage of the disease, grade of the disease, histological tumor necrosis. And when you put those numbers in, it spits out a number that tells you what are the risk of cancer coming back versus not. Similarly, there's another one, S-sign, looking at the stage, size, grade, and necrosis, and helps with defining those patients who have more aggressive disease and have higher chances of tumor coming back. Again, one of the widely known and used in clinical trial is UISS, developed at UCLA, Los Angeles, using the stage of the disease, ECOG status, and firmer nuclear grade, and gives a chance of low, intermediate, and high risk of tumor coming back or not. So I'll give you 2 examples just to kind of see like how we were treating different patients. For example, this is a 60-year-old female who had a good performance status. She's otherwise very healthy. And again, they found an incidental tumor in the kidney, measured around 8 centimeter. There's no evidence of any metastases. Blood work was all unremarkable. She underwent a surgery, kidney was taken out, and it shows actually a stage 2 cancer, clear cell, one of the most common type of cancer. In grade 3, there was no necrosis. There were no other bad features in the cancer. Margins were all clear. She was labeled stage 2 cancer. On the flip side, there was another gentleman, 55-year-old smoker, good performance status. He has a bit of hypertension, some symptomatic presentation, upper abdominal pain, and blood in pee. And the CT scan shows something like this, a big tumor in the kidney, which is also going into one of the vein and also into the IVC. There was no evidence of tumor outside the kidney and anywhere else. So he also underwent surgery and tumor thrombectomy. And final staging came back as PT4, means the tumor was going into the adrenal gland next to the kidney. There was necrosis, there were some bad signs, grade 4 disease, but again, negative margins. So this would be labeled as stage 4 cancer. Unfortunately, both of them until this point were treated as waitful watching, so that we would be watching them very carefully, closely. Of course, the stage 2 cancer maybe not as frequently, stage 4 cancer more frequently, 3 to 6 months imaging and blood tests. If we plug in all those risk scores that we were just talking about, so this gives us an idea on the first patient, the risk of cancer-free survival in 5 years is about 70 to 80%. But on the other side, for a second patient, it's very poor, as you can see. So there is significant difference in prognosis. Both patients until this time were being on surveillance, only waiting for cancer to come back and then do something about it. So this, I think, highlights, and it's very important, the unmet need of effective adjuvant therapy, meaning when the tumor is all out, can we do something, some treatment, some medication to prevent that tumor to come back? And with this, I'll invite my esteemed colleague, Dr. Lalani. Thank you very much for your patient listening. Do you want to take question? Yeah, for sure. Yeah. Okay, I'll be happy to take any questions.
Well, actually, I'll get you started. I think. Yeah. Thank you. I'll do it. Oh, sure. First question, I asked you in an email about ablation
Mhm.
as a treatment and then adjuvant therapy, or does it have to be surgery? Could you?
Excellent
enlighten
point.
us?
So the trials that were recently published, all of them had some kind of surgical treatment. I would also mention that some of those patients, for example, if somebody had tumor in the kidney, but also isolated spot in the lung, for example,
Mhm.
in some of those trials, they allowed surgery and ablation of those lung nodules or something if they were isolated, and
Okay.
then to be considered in those trials. But by and large, and I think Dr. Lalani can correct me if I'm wrong, the studies did not allow just ablation and then consider them for adjuvant therapy. Why? Because ablation alone does not define the full extent of staging. For example, if ablation is usually done for about 3 to 4 centimeter tumor,
Yes.
not larger than that,
Yes.
and 3 to 4 centimeter by definition would fall into stage 1 category, unless we remove it and see if there is invasion into the surrounding fat or blood vessels around the tumor. Then they become stage 3 when they will be eligible for adjuvant therapy.
Okay, thank you.
Yeah.
Does anybody else have a question for Dr. Bansal in regard to surgery or something else about localized disease before we continue? We're all good? I have to tell you, I've learned 3 things already and I've been in this business a little while, so.
Oh, I done my job then.
You
Thank
sure did.
Yeah.
Thank you so much.
Thank you.
Dr.
Thanks a lot,
Lalani, can we
everybody.
have you join us?
Okay, great. Well, thanks everyone for coming today on a Monday, and really to the whole team for having me. Christine, who's done with the whole board, we did a lot of work to champion for kidney cancer patients. I think we're very lucky in the GU world to have the kind of interactions we have, and we assume it's happening everywhere. We see breast cancer work, lung cancer work, but I can tell you one of the largest GU cancers is prostate cancer. And I'm not sure that we have the same presence in Canada for patient-facing groups. So Kidney Cancer Canada and all the stakeholders who have been there over the years deserve a lot of credit. And obviously, folks are here today and will be listening at home for this as well. So I just want to give you guys a big shout out, because it matters a lot to us in clinic when we can say, hey, and there's a advocacy group for you. I think patients really identify to hear something from them. So I'll just briefly introduce myself. I'm a GU medical oncologist at the Adjuvant Cancer Center. I'm an assistant professor. I lead our GU disease site team at the Hamilton Health Sciences. I have lots of other research institutes, and I'm a scientist in various places that are really trying to understand cancer discovery and drug development. So I'm really here to take the baton, because we didn't really exist before as a medical oncologist in the post-surgical world. So trying to understand where we are, what role do we play, and why are patients meeting us? And I think we have a very good pathway for patients here in Hamilton that probably doesn't exist everywhere across the country. These are my disclosures. I work with a lot of companies, none of which are directly biased or have any direct input into my slides today. So just some definitions, because I think sometimes we get so used to and trained into using some language, and I just like to ensure that in the clinic we're talking to patients in a way they understand, because there's lots of education levels. Many people Google. Kidney Cancer Canada can help patients understand things. But just from my talk, we say kidney cancer, we often mean renal cell carcinoma, and that we abbreviate to RCC. Adjuvant therapy, as I think this group now knows well, is treatment we do after surgery. We've had some conversations about ablation, but generally it's a cancer principle. You cut a lung cancer out, you cut a kidney cancer out, what can you do after? Metastatic therapy is treatment for cancer that has returned after it's been cut out or has shown up or spread. And that's still systemic treatment, but it's a different context. I won't be talking about that today. And then what I call IO, or you might Google and hear about IO or immune therapy is IV treatment, not chemo, ramps up your immune system to fight cancer. And then TKI therapy, or you might hear about eras where we had targeted therapies. These are oral treatments, not chemo, but targeted pills that are really predefined to help in kidney cancer. So if I use this jargon, hopefully it makes sense to everyone here. So a bit about my journey, just to introduce, how I've gotten here. And I like to say, my mom had a much more exciting journey coming from East Africa. I'm boring. I was born here in Vancouver, so nothing exciting there. I went to Queen's for my undergrad because I like biology and chemistry. And at the time, they had the best biochem program. So I said, okay, I'm going to go there. And then, journey has taken me in a lot of different places. I did my internal medicine in balmy Winnipeg. We did our interviews in February for CARMS. And so luckily I was a hockey player growing up. So playing on the Forks outdoors was fine for me. But I learned a lot there. And wouldn't you know it, both Rahul and I, our paths overlapped in Winnipeg at some point. So amazing how the world works. I did my medical oncology at Cross Cancer Institute, another warm climate, and then made my way to Boston at Harvard at Dana-Farber, where I did my medical oncology fellowship, really specialized in kidney cancer with Tony Schwery. So a couple of things to take away. One, I've seen a lot, despite, being more, I guess, junior in the career compared to some of my colleagues who are retiring. But, I think you see a lot. And one of the advantages of that is you get to see how different systems and people work. I think for us, having gone through training and now being mentors for other mentees, you build a board of directors of mentors across the country. So I feel like I can reach out to a lot of folks with questions. I've seen stuff above and below the border, right? Seen how the US works and how Canada works. And I would say all along my way, one of my hooks to come to McMaster was Dr. Kapoor. I wanted to make sure when I came that I was purposeful. Kidney cancer was a passion. I wanted to treat GU. I wanted to ask questions in kidney cancer. And I thought I had no better partner than someone like that over the years to work with. So I get, and I think you've seen it's not just me, Dr. Bansal, and there's a legion of folks as well who are really touched by him. So I think a lot of what we do is to maintain the high bar we've set at McMaster and that Dr. Kapoor really led for decades. And so I take that as a burden that we need to do. And so certainly a shout out to him. So this is really, the first two slides are about drug development, because I think many people feel like I've got my kidney cancer cut out. Why am I hearing about other treatments? So let me just tell you how we define things. So how can we use, this is cancer medicine in general, okay? How can we use medications in cancer care? So you can give patients treatments before they get surgery. That's called neoadjuvant, something to help maybe lead to a beneficial surgery. Or you can do what we'll talk about today, which is have a surgery and then give treatment after. That's adjuvant therapy. Then what you could do is you could give treatment that happens if, unfortunately, cancer has spread. And luckily in kidney cancer, we have multiple lines, or what I say, tools in the toolbox to give for treatment for spread cancer. This is broadly, no matter what cancer you have, this is the way doctors are thinking about giving folks treatment beyond or in addition to the knife, okay, in terms of cutting it out. But how do we actually develop this? So how do we do drug development? And this is the way it actually goes. So because of patients who have had a spread or stage 4 cancer historically have had, the more challenging outcomes, drug development generally starts in this setting, right? This is the most frail of the frail. You want to make sure you're really helping these patients first, and you're likely going to see endpoints for these trials quickest. So we start with treatments that work in a spread setting. Then it's found to be proven helpful. So for kidney cancer, it's immune therapy. And then we say, well, what about we use it in a after surgery, because it's helped folks with a spread cancer. Let's do better. Let's start sooner. So then we study it in patients where it hasn't spread, but they've had a surgery, we cut it out. And then we say, well, it's worked here, it's worked here, now let's try it here. So this, for you guys, you can see this is a sneak preview of what we're currently thinking in kidney cancer. We have immunotherapy that's worked here. We're now finding treatments that work here. And now some of us who are designing and writing protocols for the next wave of trials are trying to intimately understand, can we give treatments before you even have a surgery? That's what I hope will be if we do this meeting in 27, 28, 2029, or 2030, that we'll talk about treatments before surgery. So with that in mind, this is what has existed for patients with kidney cancer, so solely kidney cancer, whose cancers have unfortunately spread. Now, I bring this up not because I'm going to talk about all this, but there is an era where there was old school immunotherapy Then we learned targeted or oral pills worked for spread cancer patients. And then we found that immunotherapy, one drug or maybe two drugs work. And so this is where we've gone with stage 4 kidney cancer. So you already know what's going to happen. You're like, oh, I know he's going to show me slides of what we do kind of now after surgery because it worked there. So for adjuvant therapy, so we're trying to take these drugs now to folks who have had a surgery. So how do we do this? Do we just expose a million patients around the world to drugs after surgery? No, we think about it carefully. So we say, okay, there's going to be a lot of patients where surgery in Dr. Bansal's hands, other surgeons' hands, they're going to be cured. These patients are good no matter what happens. Then there's going to be patients who, unfortunately, despite the cancer being cut out, so you've heard a little bit about when that cancer is pesky and has gone in through the vein and is heading up to the heart, that doesn't seem so good. But even if you got part of it out with the kidney, those are patients that we think, well, we got it all, but there's probably something left we can't see yet. Now, some of those patients, no matter what you give them, unfortunately, that cancer is going to be resistant. So we don't know that well enough in kidney cancer yet. We're studying this. But in between, there's going to be patients where it was cut out, may not necessarily be cured, but the disease that is remaining is going to be very sensitive, meaning we're going to be able to get on top of it with therapy after surgery. That's kind of the ideal scenario, right? Find these folks and give them the right treatment to help them be cured as long as possible. And so what is a challenge? Well, we say RCC, remember that renal cell carcinoma, kidney cancer, same kind of stuff that we say. And we think clear cell, and that's usually the most common, right? Pathologists years ago, and there's no pathologist in the room, so I'm going to make it really simple. They looked at cells because of how kidney cancer looked. It looked clear. It has certain elements to the cell, and that was all binned as clear cell kidney cancer. And then there's a bunch of others that were kidney cancers, but didn't quite make sense. So they just called it non-clear cell. Part of my research interest is getting into the weeds about this. So we now really call it variant RCC, not just non-clear cell. There are lots of different stepchildren of a family. They're all different, right? They all behave differently. So these are why when you're either have a biopsy pre-surgery or have a surgery, your urologist, your surgeon will really look at the details of what is that kidney cancer that we cut out and what type of cell type it is. Biology is king and treatments are queen, I guess, is the way to put it. And so biology will really drive how patients experience things, but the treatments have to be tailored towards this. So when we develop drugs, we're trying to understand, okay, all the trials are going to be for these patients, but what about folks who have these rare ones? That's what I think about a lot at night or on the weekends, is how do we understand this better? And so a lot of us think about that. So your urologist will look after a surgery for kidney cancer and try to understand what kind of cell type is it. So that's the adjuvant setting. And how did these drugs work? So I'll take like 3 decades of work and 2 Nobel Prizes and put it together in like 60 seconds, okay, for kidney cancer. So our body has immune cells that is hunting things that aren't you and that are foreign. They're trying to harm you. Maybe it's a COVID virus. Maybe it's a kidney cancer cell. So once there's a kidney cancer cell in your body, this the neighborhood watch, right? That I don't know if there's still neighborhood watches around. I think there are. Okay, so there's still neighborhood watches. So they drive around and then they say, okay, well, I see something that doesn't look like me. And they send a signal back to central dispatch and say, okay, you need to unload a bunch of immune cells because we're finding this stuff. It looks like kidney cancer. It doesn't look good. So immune cells get primed and active, and then they get into a car and go down the highway and find out where this cancer is. They infiltrate the tumor, and then they go and recognize the tumor and they kill it, right? That's your immune cells. So clearly we don't want this happening all the time. We want this on, but we don't want this all the time. So our body has checkpoints to kind of calm it down and say, enough, your immune system's active. Let's chill. We're good. We dealt with this virus. We dealt with this parasite or whatever. But in a cancer setting, you kind of don't want any checkpoints. You just want everything to be ramped up. So you can give treatments that, for example, in the bottom, I guess, right of your screen, that can take the cloak off the cancer cell because it's trying to hide from our immune system, right? Tell the neighborhood watch, nothing to see here, just keep going. So that's what some of these drugs like pembrolizumab will do. They'll take the cloak off the cancer cell. And then you might want to give drugs that ramp up the pouring out of immune cells into your body. So that's drugs like ipilimumab. And then the guys that try and shepherd you down the highway to say this is the way to go, these drugs can help make this whole cell immune system work. So people did like decades worth of work to get to what I just said, and they won Nobel Prizes and their whole careers are made. But that's essentially how we're trying to do that in kidney cancer in a nutshell. So remember I showed you an era of oral pills, targeted therapy. So very smart folks around the world, way before my time, but they all said, well, let's give folks who've had a surgery for kidney cancer, give them pills and let's see if it reduces the chance of cancer coming back. And on the far right here, this is if the result, if when they did their exams, they helped folks live longer by doing this. That's overall survival. None of these things help patients live longer. One drug maybe helped folks delay the time of cancer coming back, but oral pills were not helpful. It was important to study. Basically, that's why we don't do it. So the question became, when we developed immunotherapy for stage 4 cancers, yeah, I mean, you guys can develop drugs now. You know where it's going. They found immunotherapy. We know it works in stage 4 disease. Now let's do it after surgery. So lots of companies and smart folks said, well, let's give a drug like an immunotherapy, a atezolizumab, or a drug like pembrolizumab. Different companies, different trials, all competitors, all trying to figure out if we can help win. There was one trial that said, let's give a whiff of immunotherapy before and after surgery. And there's lots of these trials out there. So all of these were conducted. Look at how many folks around the world were enrolled to help understand this better. So we'll focus on one study, and I will be fair and talk about all of them, but just give you the summary. So this trial, Keynote 564, we had this at the Jurvetski Cancer Center. We met patients after surgery, talked to them about a drug in this study. This study was open. We put patients on. The study closed globally. We finished accruing, and this data became published in New England because of patients in Hamilton taking faith in their surgeon and their medical oncologist saying, hey, this is a trial I'm willing to be interested in. Voluntarily, of course, but they gave us a lot of their faith, and it helped move the field. So they took patients, and you heard from Dr. Bansal, right? Based on your T stage or maybe the kind of bad prognostic features, some patients who had a cancer spread, but all of it got cut out and removed, and everyone's excited. So all these patients were included, and they either got a year of placebo, which I don't know as an investigator. I don't know if you're getting placebo, or immunotherapy, because it's a trial, it's an experiment, right? We need to learn this first before we start rolling it out. And so you never thought you'd come to Monday evening and look at charts and graphs, but you're going to learn, okay? You guys are all going to develop drugs in kidney cancer now. So what did the results of this test show? So the endpoint was looking at something called disease-free survival, essentially the time on to delay the cancer coming back, or God forbid, a patient dying. But really, in a post-surgery setting, the number of deaths are quite low from that. It's more of if cancer came back. So in the first analysis, there's two curves, right? Because everyone at the start is alive and well. And then at some point, there's some patients that aren't doing as well as others. So this bottom curve shows the patients who just ended up getting surgery and placebo. At 2 years, you know, 2/3 are alive and well. It just shows how good kidney cancer surgery is. But if you can help folks do 10% better, right? So instead of 2/3 of the patients doing well, more than 3/4 were alive and well. Is that worth it? And that's this intervention here, the pembrolizumab drug. And they updated the findings 6 months later, probably a bit too soon in my books. But either way, the magnitude of benefit, meaning the curve that just got surgery and the curve that got surgery plus 1 year of immunotherapy, there's a difference, right? You can see that. I mean, I'm not trying to convince you. I think you can see there's a difference between these patients. And so it shows that this is a therapy that helps you delay the chance of cancer coming back. US FDA approved November 2021. Under a year later, CADTH already, that's the Canadian basically approval agency as a whole, not only had it approved, but recommended it be reimbursed in Canada. So there are some, really this slide is not to go through in detail, except to say, because we think about this deeply, if we see patients, and I think we do a very good job in Hamilton of making sure folks who get referred see a medical oncologist, hear about this, we'll try and understand from your pathology, you know, the sample we got from your surgery, to say, would this patient have been in the intermediate high risk group? Would they be high risk? Or was this the kind of patient that had a kidney spot, a lung spot, both were cut out? And now we're trying to understand the magnitude of benefit, the difference between the two curves. All these curves, this light blue with the treatment drug, these patients have a higher chance of being alive and delaying the cancer coming back. And of course, it varies by time, but either way, I think you can see that really this drug helps a lot of these patients live longer, and at least with cancer-free, their overall lifespan, we need to still think about. I mentioned this earlier, there's some features on your pathology that we'll look at. So some of the bad sprinkles, the sprinkles that make a more aggressive kidney cancer, are things called sarcomatoid features, none of which you have to memorize, but it's just to say this is what we look at. We try and understand this, and we see that patients who have this kind of a bad feature, I think either way, do well no matter what, present or not, but it just shows that all these patients seem to benefit. Now, one of the questions, what we can't answer to patients, and it's not because we don't know, no one in the world currently knows, is whether this treatment helps you live longer. We can delay your cancer coming back. The question is, will you live longer? We don't know that yet. You might say, well, these curves look like there's some daylight. Maybe I can get a laser pointer in here. So maybe these curves are a little bit separate. It's too early to know, right? The follow-up is 30 months. And as you've heard, patients who have a curative intent surgery are going to be living for a long time. So to test this experiment, you need to follow folks out 5 and 6 years, and then we can look back and say, was this helpful or not for your lifespan? But what we do know is up front, the chance of delaying the cancer coming back is better if you're in these groups, if you get a treatment. So that's one experiment, one test, right? One child in the household did it, pretty successful paper. So now we're going to have other folks testing it. Cousin medications, did it work? Yeah, and this is what's complicated. This is why these consults, when we have it with these patients, we take time in clinic, because we have to say, look, we're really enthusiastic. This one drug that is Health Canada approved, that we can give to human beings in Canada, that in Ontario is paid for by the government for folks over the age of 65, and we find ways to get it no matter what. But that is exciting. That's this, positive trial. What we don't know is for treatments with cousin medications, like another drug that's similar, a little different, 2 IV drugs in a post-surgical setting because they work in the metastatic setting. None of these have really been replicated yet. So we have to be honest to say other experiments have not necessarily borne the same results, because it's nice to have a bunch of experiments and all of them show the same thing so we can pick all these options. So it's really just to say that one drug has clearly been successful here, and that's why the government and Health Canada have approved and reimbursed it in Canada. So, this is what we do every day, right? Dr. Bansal and I have a clear referral pattern. I'll show you how that works. But, sometimes it's hard for physicians to understand who don't live and breathe it. But we had a meeting in October of late last year. I have to say this was probably the last official paper I published with Dr. Kapoor, who was our lead at the time, but he's second author on it. I was fortunate to lead this. But it's essentially a consensus statement that all of us, all experts who treat kidney cancer at that meeting who were there, could then come together, do some voting, and say, where do we place this data? So I'll just tell you that for physicians, this is not really something we want patients to have to worry about, because this is a very physician-facing statement, but it was to try and educate all surgeons, medical oncologists, coast to coast, and it's been downloaded across the world, to say, how do we approach this game now that it's changing? Because 20 years ago, 10 years ago, 5 years ago was really surgery and watchful waiting. We'll see you after. So we think about all these things just to reassure you. Your doctors are thinking, hey, this reduces, it improves the chance of being cancer-free. Which patient is most going to benefit? Does it help my patient live longer? It's pending, right? So it's an open box still. And then we're going to talk to you in clinic about how safe is it. So there's real gains with this treatment, but there is a chance of side effects. If your immune system gets too excited, there might be an immune adverse event. What is the chance of that? And what is the chance I'll need steroids to calm my body down? And we have to go through that with patients to make sure it's safe for them. And still, these patients, even who get steroids, might be doing well from being cancer-free for a long time in this post-surgical setting. So it's really just to reinforce, and I would just put a shout out to the research institutes, to the KCC, to all our generous donors, patients, their families who are generous in giving, is just to say, I think kidney cancer is, great example of how when you live and breathe this stuff and you work together, it really pushes the needle. So we have urologists who you've heard from today. They meet you, they give you this diagnosis, they talk to you about biopsy, surgery results, and all that. They'll talk to you, if you've heard about cutting the kidney cancer out, and I think we have a great relationship to ensure that these patients are being followed. they're the initial entry point, right? So they'll kind of initiate the referral to someone like myself to say, hey, as a medical oncologist, we think this patient would benefit from hearing about IV drug therapy. And then we can always leverage, generally in a spread setting, but sometimes for localized treatment, but in a spread setting, where could cancer benefit from radiation? We have a radiation expert in this city who we work with, who again lives and breathes kidney cancer. So it's nice to work with folks that we all can really help our patients across the entire spectrum. So this is how it works in reality. If you or your friends or family members ever have a surgery, these patients will meet with a urologist and have the surgery. Within 3 months, as you've heard, there's a referral, and we have a very clean referral pathway here in Hamilton to have our patients see a medical oncologist like ourselves, and then we'll decide on the treatment plan and then be able to have follow-up. I think the great thing we have established with Dr. Bansal and other surgeons is to say, the surgery is done, pathology is reviewed with the patient, referral is made to someone like myself, and we're already kind of coordinating the follow-up CT scans that even if patients say, thanks, I appreciate this information, but I'm going to take my chances just watching it and not doing IV treatment after, that these patients still have follow-up. Doors don't close for you, right? You're still followed very closely, but it's to show that that relationship occurs and nothing falls through the cracks. So I'll pause there and just say, what does this mean for patients with RCC or kidney cancer? I think multiple providers are working together from the minute you meet one of us for diagnosis, treatment, and maintaining your care at St. Joseph's, the Juravinsky Cancer Center and Hospital, and within the whole Hamilton catchment, right? So we have multiple corporations, Hamilton Health Sciences, St. Joe's. We have tons of hospitals in this network. But your kidney cancer team, just so you know, often discusses your case at tumor board, obviously with appropriate protections of your personal information, but it's all evidence-based within our tumor board, what we call multidisciplinary case conferences. We sit together, Rahul, tomorrow. So we'll have our tumor board tomorrow, actually, at 4:30 to 5:30. So we'll have folks like myself, I'll be chairing it, and Dr. Bansal will be there providing a urology voice. We'll have radiation doctors and pathologists and radiologists reviewing patients. So we have all this together. This is who attends these rounds. These are serious people who care about kidney cancer. If you're undergoing treatment for localized RCC, you generally hear about surgery. Maybe you'll hear about other treatments that can help keep things under control. And just to put it out there, that there are medications like immune therapy that can help maintain cancer control. And that's what adjuvant therapy is. It's been there for breast cancer. It's been there for colon cancer. It's been there for lung cancer. So we actually have options in kidney cancer. And ask about clinical trials. I think KCC does a great job of saying, ask your doctor about this or inquire about this. There are trials, and Hamilton has been a leader for that. Another initiative which our research coordinators in the back, I think, can speak to is the Canadian Kidney Cancer Information System, where we have so much data entry for patients. Why is it so challenging? It's because we're one of the leaders across the country. Even I think maybe Toronto is catching up, but we're pretty much one of the leaders in patients that have enrolled through our database. And we don't just sit on that. We publish a lot of data from this, of course, anonymous, but your entry helps us understand how to apply this, and it moves the needle in the research world. So I think we're an innovative group, and we love treating kidney cancer and looking after you. So thanks so much for your time and being here.
Thank you very much. We'll take a couple of questions.
Sure.
Okay, he did a really good job too, because I learned a whole bunch of new stuff. So I'm anxious to get it going on our website in our coffee chats. And does anybody have a question? This is a lot of information to take in, but you did an excellent job. Thank you so much. I have a couple of questions.
Great.
Thanks. As Christine said, we've been listening to these sessions for years, and it's still learning lots. And
Great.
I like how you present it. The question I would have is, what's the regime for the adjuvant therapy? Like, how often, how long, and do you do it over multiple years, or?
Yeah, great question. And I think something we should clarify, and we do sit through and tell patients directly. So the way we decide these regimens is obviously built off of a clinical trial, which is a recipe that is designed years in advance before it becomes approved. So this particular approval is based on this trial. And I'm showing this slide because you can see here that this drug, in this case, pembrolizumab, is given every 3 weeks for 1 year. Okay. Now, we have ways of how this medication is made to give it over every 6 weeks. So that just means a double dose for 6 weeks. So meaning instead of once every 3 weeks, you could come once every 6 weeks. You know, the trial wasn't designed to look at that, but there is some safety around this. We will talk to patients about whether we think it's safe to start it every 6 weeks or demonstrate safety over a bunch of every 3 weeks for a while. But that's generally how it is, and it's 1 year's worth of treatment. And so for some patients, obviously there's some nervousness about, wow, what does it mean to get IV treatment? They go to a suite that's called the chemotherapy suite in many cancer centers, and I've tried to have them rename it, but it won't be called the immunotherapy suite yet. But anyways, they're like, you know, they're not getting chemo. So that's another thing that when they practically get it, they think about, oh yeah, I'm getting immunotherapy, and it feels different. Like I'm sitting here and it feels different than a patient next to me who might be getting chemo. And that's really the point of the advancement of immunotherapy. So, but to answer your question, it is every 3 weeks. We don't necessarily ask the patients to come every 3 weeks and see a doctor as well every time, because there are times our pharmacy teams or our nurses can check your blood work and make it more, you know, feasible for patients, because by definition, these are patients that have had a successful surgery or are yearning to live life. And so anything we can do to even save a visit would help. But that's generally how it is, 1 year's worth every 3 weeks. That's the cocktail, so to speak. And then sometimes we can double up and give it every 6, which would limit the amount of IVs they get. The IV occurs, it's in an IV, much like how you probably get sedated or get IVs for other procedures. It's an IV, you get your IV treatment. Once the treatment is done, you take your IV out and you go home and you live your life and hopefully forget about us until the next visit. And so it's actually doesn't need a port or a PICC line in general.
Hi, can you speak a little bit about the protocols or the rules, I guess, surrounding qualifying for adjuvant therapy? Because in my situation, I went from radical nephrectomy to bilateral RFA, and then I had meds to my lung and then meds to my lymph node. Adjuvant therapy wasn't offered to me, probably from a timeline perspective. So can you speak a little bit to that?
Yeah, so a couple of things. Just on the timeline perspective, you know, it's a very good point. You know, we think a lot about patients 5 years ago we would have loved to have had this conversation with, but couldn't now. And it's only because we can ethically have these conversations once approved, which I know you know, but it's just to reassure patients at home if they said, hey, I had my nephrectomy years ago, why didn't I get this offer? This wasn't withheld from you. It's just to tell you that, look at the bottom right, these weren't even approved in Canada until late 2022. So in terms of which patient would be eligible, and this is where we have our relationship with our urologists who do a great job. But if you had, first of all, you have to have a kidney cancer that's been completely removed. Okay. It is largely clear cell, which most patients in the world will have, and that's on the pathology report. If folks have PT2 and a bad feature like grade 4 sarcomatoid or PT3, that would meet. PT4 would meet. Node positive would meet. So really anything PT2 or higher. And then the patients that are really interesting that this trial allowed, and Tony Schwery is who I worked with in the US, and I'd asked him about this when this was happening, is folks who have had a kidney cancer, but also at the same time, unfortunately, had it spread somewhere else that could be removed. Okay, so both parts removed. Those were situations where it was felt that the cancer has been largely removed. Now, there's spots that maybe couldn't have been removed. For example, let's say it was in the kidney, cut out, but the bone maybe couldn't be, or maybe it was radiated. Not all patients can have surgery, some can. Sometimes the cancer came back years later somewhere and then was removed, but that's not within the 12 months of getting your initial kidney surgery. So there are some rules around this, and luckily we work together. None of this happens in isolation. This is not new slides for Dr. Bansal to see either. So we kind of talk about making sure all of our patients who have had surgeries know that and trigger a referral that way. But that's generally how now going forward, really in 2023 and beyond, if you had a surgery and had it removed. I don't want to speculate about your particular case, except to say that for patients who have had, let's say, treated in the past, luckily have done very well prior to adjuvant therapy. And if their cancer has come back again, doctors will think about radiating, cutting it out, And then when it comes time to get systemic treatment, you'll be referred. So this is just one horizon of folks after surgery, but in the spread setting, there's lots of tools which I haven't talked about as well.
Oh, thank you so much, both of you, for your presentations. I'm going to bring in the Western view. I think I spoke to both of you. Unfortunately, in Canada, when you use the word Canada, I think we have provincial Medicare systems. And my wife, who passed, who I mentioned to some of you, Duncan's sister, my wife, passed last year, but she originally had 8-centimeter T2 tumor taken out in Calgary in May of 2013, sent on her way home, got it all, radical nephrectomy, adrenal gland, 8-centimeter tumor, not found anywhere else, and then was followed on. So in today's world, it gratifies me that there's other adjuvant optionality available, because she had previously in her life, about 9 years prior to that, had breast cancer. And as an oncology nurse, she worked at BC Cancer Agency and Tom Baker. I think when she had her tumor out and was sent on her way, that caused alarm bells to go off. I know it did, because there wasn't the same, here's radiation, or here's chemo, here's tamoxifen for 5 years. Like, there was a set plan after breast cancer to stop it from coming back. So I think what I'm hearing you say now is the optionality is greater. The only part I would add, though, is whether it's Dr. Kleinenberger, I think Coleman'sberger at BC Cancer Agency, and I think they had the POG program there. We had Dr. Danny Heng at Tom Baker, and there's Cross where you were. Is what you're talking about across Canada, or is it just regionalized?
Yeah, no, so great question. So first of all, obviously, thanks for sharing about your wife and obviously your sister as well. We think a lot about this, patients who just by the snapshot of time couldn't have the treatments that are available now, but we think a lot about them. So when just very briefly, when a drug is largely, when there's data like this trial, right? When this comes up and we're at conferences, so I'm going Wednesday to Madrid for a similar conference where there's going to be data on kidney cancer as well. We see these slides, we get really pumped and excited. Then the companies who have sponsored this, or if it's an investigator-initiated trial, will submit to countries around the world and say, hey, we think this should be available in your country. That's largely going to get Health Canada approval, meaning, can we give it to a human being in Canada? And then CADTH will come along and say, okay, here's this file we need to pick up. Health Canada has approved it to be administered in Canada, but do we think it really meets the bar of being something that we should challenge provinces to reimburse? There's more nuance to that, but essentially that's the process, okay? And so CADTH, when there was recommendations in September of 22, then you're right, each province will go through that. Luckily, we don't allow each province to just do this willy-nilly, because can you imagine like little Canada and each province going to like negotiate all these drugs, and this is kidney cancer and doing it for lung? It'd be a lot of work. So again, without simplifying it too much, except to say that the provincial authorities can kind of come together and negotiate and say, what would it take for this to happen? And so all those steps have really passed that up. And I believe Atlantic Canada is on board, if I'm not mistaken. So I think, because some places, you're right, do take a little bit longer. As a whole, post-surgery treatment for kidney cancer should be prime time across provinces. I will tell you that one benefit we have in our group, because we work so closely and see each other a lot, is we have not created a barrier for patients. We have taken the approach to say, if you meet eligibility based on this trial and the government has approved and is reimbursed, we want patients to hear about it. Whether patients decide to take it or not is a very personal decision. And the reason I bring that up is, and again, I don't want to comment specifically about any other center, it's just that some centers have decided as a group, they don't think maybe this magnitude of benefit is enough, or they're not recommending it generally for their patients. So patients may not be hearing about it in some provinces. I'm not saying that I know that for a fact in kidney cancer right now, but I know that does exist in kidney cancer in some other provinces elsewhere. So I believe out west, it's quite well known. I mean, Dr. Coleman'sberger, Dr. Hang, we're all going to probably be in the same city in 2 days anyway. So it's just to say that the experts know this. It's our view in Hamilton has been, it's not our job to block whether patients hear it. We've taken the approach that these patients should be referred to here, and then they can make an informed decision. And it might be a coin toss. You know, it might be a one patient says yes, one patient says no. You know, doctor, for me, I appreciate it, but this is not what I'm looking for. We can accept that. I think our approach has been that we wouldn't want a patient to be blocked from hearing.
I appreciate that, and thank you. I don't need the microphone. No, the only follow on, and it just stuck in my head as we were chatting, and because Adjuvant wasn't available 10 years ago, for sure. Renal cell carcinoma, also for what Nancy had was variant, and I was glad to see that 2 of your studies, research studies at the bottom of the 5 said any renal cell carcinoma, because she had translocation XT11.2, which is the rare version, extremely. But it makes me think when you're doing adjuvant, that takes one potential line. When Nancy was having hers, sometimes if you had a line, later you may want it if it had some benefits, but they go through other lines, but you couldn't re-challenge.
Yeah, great question, and lots of great. I didn't have, or maybe I didn't show the current algorithm, but it's in our consensus statement. So it's a great question to say, doctor, if I take this treatment now, how does it affect what I get later for the tools in the toolbox that I like to say? And I can just reassure you, because it's a good question, that if patients get adjuvant therapy, they receive it for the year, they finish, and they're able to, you know, live and have a functional life and be followed again thereafter. God forbid, but if their cancer were to come back more than 6 months after the IV treatment is done, the clock resets, meaning Canada has taken a view to say, we reset the clock and all the tools are available.
That makes all the difference.
I think it does. I mean, I would want that. And especially if it has been found to help a patient. You know, I think a lot of us at the time, and certainly in the Ontario language, we wanted to ensure that that was clear and available. So just to very good point you're making. And for those folks, I guess this is being recorded at home, and for them to know as well that if you receive your treatment safely and finished, there is a bar where you can reset the clock.
Thank you.
Yeah. Sure.
Given that this was just approved just over a year ago, is there any studies or any thought to revisiting some of the patients that would have had their surgery just prior to this being available? Sort of, I think right now you're saying you come back after 3 months and then you're assessed.
Yeah.
What if you had surgery a year ago? Would you consider if the patient wanted or was stressed out about it?
It's a great question because, again, some patients would have just missed, like approval came and they're like, this is like within 12 weeks of surgery to get treatment, and approval came and it's week 16 for them. Our position statement at the time was carefully worded to say, we think it would be reasonable for the patient at week 16 to still get treatment, not because that was the approval, but we just thought as physicians, we wanted to make a statement, even if Health Canada didn't. Now, for your larger question about what happens if someone is now a year and a half out, we are a bit bound by the approvals. These are drugs that cost probably $8,000 to $15,000 a month. Don't quote me, but by province, that's usually what it is, something like that. So understandably, in a tax-paid system, they want to make sure that it's approved. There are wrinkles I think about a lot as a physician. So I don't know if you can see the bottom of this, but what if a patient had surgery for a kidney cancer? Maybe you guys can see this marker, but they had a kidney removed, and then something came back at month 11 after surgery, and we cut that out. So the time from their nephrectomy to the spread spot being cut out was within 1 year. Technically, you'd meet that, I'd consider it this, and then you'd meet this criteria. So now again, that's not for someone who's had a surgery and is sitting at home chilling, right? This is for someone where it came back within that year. The second layer to that, I would say, is the next generation of this trial, which is already probably closed, and we had that open very briefly, but it recruited so quickly, was the belzutifan trial. So pembrolizumab plus or minus belzutifan and another oral pill that allowed this whole kind of within 1 year to be up to 2 years worth. So you could have had your nephrectomy, God forbid cancer came back within 23 months and that was cut out, then you could get onto that trial. So we are thinking about broadening that, but I don't have an exciting answer for patients who are sitting at home 2 years out from a nephrectomy, except to say you are 2 years out from a nephrectomy. And there are many patients who will do well, right? Even on follow-up. It's just that we want to raise that bar. And I hope the next time we see this, we can raise that line, right?
Okay, I can project.
Okay, thank you.
Thank you so much both for the presentations. I noticed on your eligibility it focuses on clear cell.
Yeah.
RCC. Are there any adjuvant treatments for papillary RCC?
Yeah, it's a great question. And it's part of that whole drug development. So remember, it moves from the spread setting and then the adjuvant and then the neoadjuvant. And it's the same thing. It says, well, let's take clear cell because that's like 3 out of 4 or 4 out of 5 kidney cancer patients around the world. And now we have been saying, okay, well, now we've proven it works. We're trying to do this simultaneously in more of the variant histologies. I would say if there's any component of clear cell, I think there's good reason to think it may be beneficial. But you're right, if it's straight papillary, straight translocation, straight collecting duct, straight other types, these are the variants that I talked about, right? They kept getting binned together, that we need to have trials that are in more rare. Part of my hat at the Juravinski is actually treating patients with rare tumors as well. And we're struggling the same way to say you can conduct, we can write a protocol for phase 3 clinical trial for these patients. There's gonna be a lot of them around the world. If you do phase 3 trials for like chromophobe, it's gonna take you how long to recruit? So what you're asking is for us to be a little bit nimble, I think, to say, hey, can we do maybe smaller phase 2s and push the needles for approval? I think that's helping us. For those of us who do protocols, we're thinking about that. I would say that in a spread setting, in Canada, the drugs for a spread cancer, not the point of this talk, but those drugs are all approved across histologies, clear cell or not. So right now, the adjuvants really need some component of clear cell. For some doctors, they'll say I need it to be majority clear cell. For many of us, we'll be a little bit flexible and say at least if there's a component of clear cell. If you have none of that, it's not that we know that treatments definitely don't work. It's we don't know that they do. And when we expose a patient to considering side effects, we have to be careful about that. So that's the way we think now, but we are trying to develop protocols. And that's part of the research institutes funding research programs at places like this, is to do this kind of hopefully quicker or rapid access trials to get things closer and done quicker than large randomized phase 3s.
No, thank you. How about if a family's done genetic testing? Would you qualify or
For treatment? Yeah, so right now, so it's a good question because you're asking, I think it actually asked the question, who should be getting genetic testing? We could do another talk on that. I won't take up any more of Monday for you, but except to say that there are clear indications and Canadian guidelines on who should be getting genetically tested. And so if a family member has been tested and found to have a susceptibility gene, I think they should be followed closely in appropriate genetics programs. We have not found, what you're asking about is prophylactic treatment, meaning saying, I might be susceptible. Should I take an IV or oral pill to prevent the cancer coming? We don't have that yet for kidney cancer. I think that would be a great leap forward. I think actually what I'm actually interested in is following patients before they have kidney cancer. Can we catch it earlier in blood? I think that's probably a moonshot, so to speak. But in the next decade, I think there's going to be methylated DNA testing from blood that can try and capture a kidney cancer cell or a lung cancer before it occurs. So the patients who have had maybe genetic syndromes or predispositions would be that's just a great research idea. We should think about that. But I think understanding blood typing in patients like that would do it. But right now, this therapy is approved after you've had a confirmed cancer removed and not in advance of having a cancer diagnosis yet. But I hope I can have a new conversation in 10 years if we talk about this.
Just touching on the genetic aspect, could you just give a couple of ideas who should follow up with genetics, like brothers and sisters, parents and children?
Yeah, no, this is This is great and way beyond what I thought I'd be talking about today, but we love this. So I'll just say that we actually have another Canadian guideline on who should be getting genetically tested, and I think we're going to do an update on this. In general, when let's say and Dr. Bansal and other surgeons do this independently, actually, when they see the pathology report and they find multifocal RCC, so patients where it's not just kind of one focus that the pathologist saw as like, here's your kidney cancer in your kidney, but multiple areas in that kidney, just to keep it simple, that should trigger a genetics referral, because that seems a bit different than just having a randomly acquired, right, over time kidney cancer, which is different than genetically inherited or acquired. I think folks who have had cancers in both their kidneys are ones, so bilateral, we should be thinking about. I think anyone under the age of 40 in general with a kidney cancer diagnosis, frankly, I think anyone under the age of 40 with a breast cancer or a prostate cancer or other cancer diagnosis generally would meet genetics referrals. There's some genetic syndromes. I think VHL patients should be afforded for testing, or suspected VHL. There's some other associations, some that have a collapsed lung or fluid in their lungs from a kidney. I mean, there's some unique ones, but as a whole, there are guidelines for that. And we have great genetic programs in this province. I think they're in every province. But the guidelines are really ubiquitous. So we should be pushing our genetics group to have these patients, even if it takes 6 or 8 months for the appointment, which seems like, wow, that's long. It doesn't delay your care as a patient, but it means the family, there needs to be time, right? To go through a family tree, make sure you answer questionnaires, and then be assessed. But we should have programs that are equipped for that.
Thank you. I'm sorry I took you off subject.
No, it's great. It's
And
so
just
good.
an extra point for those that are interested in genetics, we are hoping to have a cancer specialist speak to genetics and genomics at our forum in November. So stay tuned for that. Do you have any other questions? Comments?
Off the hot seat. Okay, thanks everyone. Okay.
I'm going to make this quick. Because the topic tonight was adjuvant therapy and Kidney Cancer Canada. I'm going to thank Dr. Kapoor once again, and I'm going to have to put my glasses on for this one. First, I'd like to thank Dr. Bansal and Dr. Lalani. Thank you so much for your expertise and for your precious time, because I know that everybody is busy, but I know you are full plates. So thank you so much. I wanted to say thanks to St. Joe's, the catering, Camilla. I wouldn't have been able to do this without you, so thank you so much. And next, I'd like to thank all of you for coming. Your interest and your support really means a lot to us at Kidney Cancer Canada. As we mentioned, this will be available on our website post-production. So all of this valuable information that you heard tonight will be available in the coming months, and we are happy to share it. If you have an education center, we're happy to share if it would be of value to you. We're going to talk about the adjuvant therapy decision aid, and it was created to inform patients about adjuvant therapy and to help them make their decisions with their healthcare providers. Shared decision making, that's becoming a hot topic, and I hope it grows and grows because it's so important. It is now in final draft, and we were hoping to have it ready for this evening, but as we were talking about clinical trials and gathering data and information, it takes time to make sure that everything is right and goes through the proper channels before we pass it on to the patients. Dr. Anil Kapoor was the process starter. He was an advocate for adjuvant therapy and for patients that met the criteria. He encouraged us at Kidney Cancer Canada to create the decision aid to inform patients that were candidates for adjuvant therapy. This treatment is not, as it's been explained, not for all patients, but it is for a large enough population in our kidney cancer community that it will be a benefit. So we're happy to promote it. Conversations with your doctor is essential. And that was kind of why we formulated this decision aid, to give you the information, the questions, and that you can take this with you to your doctor or study before, so you're well prepared when you have that appointment. Because as we all know, time is valuable when you're speaking with your specialist, but this helps prepare you and your doctor should be prepared to answer your questions. Now, this is Dr. Kristen McAlpin, and I think that's a great picture of her. And she was kindly agreed to be our lead author. Now, Kristen has had great experience doing other decision aids for us and for the kidney cancer community. She did the 2 Ottawa decision aids, whether to have surgery and how should I treat my small tumor. They are both on the table when you go out if you want to take a look, if they'd be a value to you. And as I was saying, that the process to create a decision aid is long and tedious. She started with the initial draft. It then goes to a panel of physicians, kidney cancer specialists across Canada, and they all give their input. And it all comes back to Kristen. Kristen takes in all their information, edits the document, and then it goes back out again. This is a 3-time process. So it's now in final draft. We've done this 3 times. We want to make sure we have it right. And once this final draft is approved, then we will be taking it to the printer and we will have it alive on our website for those to refer to. And I have a bunch of slides that I should whip through here. So this is draft, and I'm sorry I have the big draft on the front, but it explains it's pembrolizumab, what Dr. Lalani was explaining so well, and who is available. There are no right or wrong decisions. This is a serious decision that you need to make in your treatment process. And we hope this decision aid can help you discuss treatment options with your doctor, determining best how to proceed after your surgery. The decision aid, as explained before, is for you if you have had kidney cancer surgery within the past 12 weeks, you've had a tumor that was larger than 7 centimeters and growing into tissues, you had kidney cancer that spread to the lymph nodes, or this includes some stage 2 patients, mostly stage 3 patients, some stage 4 patients. This is a conversation you need to have with your healthcare provider, your specialist, kidney cancer specialist. It also gives the reasons in this decision aid who this treatment is not for. What are your options after I have my kidney cancer removal surgery? It lists all the options of receiving pembrolizumab and monitoring, and explains some what some of the processes are and what the expectations can be. And if you decide not to go with the adjuvant therapy, it also explains what the process is and what your treatment should be. This kind of gives you questions at the end, after you've read all the information, to decide whether you've adequately received enough information from the decision aid that you feel comfortable going to your doctor and knowing how to discuss this treatment. And also gives you kind of a chart on, do you feel comfortable about making your decision? These are all within the decision aid. At the top of the page, it says, and although it's hidden a little bit, this information is not intended to replace the information from your specialist, but is a complement to it to help you make those decisions, share decision making. And we will have it on our website. We will have it available for mailing if anybody is interested. And we hope to share this more and more with our kidney cancer community. We've also spoken with some of our healthcare providers who are willing to share this information with the patients that are eligible that will be coming into their hospital and clinics. So we hope to get the word out, because it is a valuable treatment option if you know the right information, if you have the right information to make the right decision. Thank you. And that's, I think, the end of the evening. I'm so glad everybody came. Thank you so much. I learned something every time, but I learned a whole bunch tonight. So thank you, Dr. Bansal and Dr. Lalani. I can't wait to pass it on to our kidney cancer community. And you know that I'll be calling on you again. We are so blessed at Kidney Cancer Canada that we have such a network of kidney cancer specialists that we feel free to call on anytime, and they were always willing to help. So, and that's across Canada. So we are very, very grateful for our community. Thank you for coming. There's still food outside. If you'd like to take a cookie for the road, please help yourself, or a coffee for the road. Please go ahead. If there's anybody that needs a parking pass that did not get one, please see me. And thanks again. Enjoy your evening.